Thank you. So good afternoon, everybody. Welcome to this spotlight session on communicating about an uncertain future. Over the next hour, myself and my colleagues, Katharine Weetman, Chloe Shaw and Rosanna Fennessy are going to be presenting to you some of the latest evidence on communicating uncertainty in serious illness contexts. The chat is available, so please do put questions in the chat. It's the message icon on the right-hand side of the screen, and we will be recording this session and it will be available afterwards on the conference platform. 1 second. So, by way of introduction to uncertainty, I thought I would talk to you about James. So, James is a case study that we've developed closely based on the experiences of one of our patient contributors, and this is based on the story of her father, whose name wasn't James, but we're using James. And just to illustrate a situation of uncertainty in serious illness. Now, James was 86, doing pretty well, previously independent at home, and unfortunately was diagnosed with colon cancer, but was felt to be well enough to have surgery for that, and he had a background of kidney disease. So far, so good. But after the operation, things didn't go quite as planned, and he's still unwell a few weeks later on. And that's it. That's the situation. It's a very simple case, theoretically. But if you think about what the future might look like for James, things are really rather uncertain. He could still improve as might be expected post-operatively. But the fact that it's been a little while suggests that perhaps things aren't going as planned, and there are other possible outcomes here. So I'm going to leave that hanging for a few moments and talk about what that uncertainty might look like before coming back to James. So what is uncertainty? Well, you can think of it as known unknowns, things that you know that you don't know, or the subjective experience, the awareness of ignorance. And that uncertainty can be caused by complexity, by unpredictable situations, by ambiguity, and also by where there's a lack of information or conflicting information. It can occur in multiple different domains, so it can be personal uncertainty about the self, it can be practical about care or the health system, or scientific about the illness or prognosis. And it can be experienced by anyone involved in a serious illness situation. It's not just patients and families who feel uncertain. A lot of the uncertainty is held by health professionals also. When we did some interviews asking people about their experiences of uncertainty, and one of the respondents said this. They said, well, my experience of dealing with uncertainty, well, it's a slightly difficult question because it's kind of the air we breathe. And in palliative care, in serious illness contexts, uncertainty is everywhere. Uncertainty can have effects in multiple domains. This was a literature review we did in the context of multimorbidity, and we found effects of uncertainty in physical, practical, social, even psychological and existential domains. People felt really overwhelmed at times, all surrounded by this continual changing situation, which is particularly prevalent when there are multiple illnesses, but it's also the case in many disease trajectories that there's continual change. So uncertainty is everywhere. It has a lot of effects. What then might be the effect of communicating about uncertainty well? Well, if we can achieve this picture on the left-hand side of the screen, this joint agenda between the professional and patients and families in a clinical situation of uncertainty, that might have a number of beneficial effects. And there's evidence that it reduces distress. There's evidence that it reduces health professional burnout if the uncertainty is in the open and communicated well. And there's some evidence about improved decision-making, and we're going to talk about some of those things today. And ultimately, we may be able to provide improved value in healthcare. So it's an important thing. We can make a difference if we communicate uncertainty well. Back to James, though, unfortunately, things didn't really go as planned here. There was lots of thinking about uncertainty. So James was wondering if he'll get better. His daughter was wondering. The health professionals wondered why things weren't improving. But what was said was, we're expecting things to pick up soon. Nobody even mentioned the possibility he might not recover until 2 months down the line, he was in the last few days of his life. And I think we can do better. So now I'm going to pass over to my colleagues to talk about different aspects of communicating uncertainty. First of all, Katharine Weetman, who is Assistant Professor in Communication and Palliative Care at the University of Birmingham, is going to talk about realist literature review on communicating prognostic uncertainty. Over to you, Katharine.
Thank you. So I'm going to present a work in progress, which is our realist review on improving communication of prognostic uncertainty in palliative and end-of-life care contexts. And this is a collaborative effort between the University of Birmingham, Cambridge and Warwick, and it's been funded by Marie Curie. So why have we chosen to look at prognostic uncertainty? Well, many people with serious illnesses would like to better understand the impact that might have on their life, including potentially how long they have left to live. So within that, prognostic uncertainty is very common, but unfortunately, this is not necessarily done well in practice. And actually, healthcare professionals may actually just avoid the uncertainty altogether because of the discomfort that it can cause. And I heard a story recently, actually, where a relative was told that their relative, who was the patient, had a very specific number of days left to live, and that was actually quantified down to the day, and it was quite heavily latched onto by other members of the family. And the conversation that I had with them was actually several months later, and that person was still alive. So they actually reflected back on the impact of being told that somebody had a specific number of days left to live when they actually continued to live for months and they're still alive now. And they kind of reflected that actually is really unhelpful. It was inaccurate, and actually for somebody to kind of position this uncertainty as being something certain and as being a known when it's not, wasn't helpful for the family and didn't really help them to prepare. And they kind of wondered why somebody would do that. And actually that's quite characteristic of what we're seeing in terms of the evidence base and the literature. So it's not necessarily done well, and it's actually kind of unknown what this communication would look like optimally, like how would we best approach these sensitive and timely conversations. So we're doing a realist review. So what is that and how is it different to other review types such as systematic reviews and literature reviews? Well, it's a theory-driven approach to evidence. So a realist review starts and ends with theory, and the focus is more on explanation rather than evaluation. So we're not looking at does it work or how effective is it? We're looking at actually how and why does it work or not? In what context might that occur, and for whom, and kind of to what extent. So realist reviews are really well suited to any kind of complex intervention because they have the ability to account for different variables and confounding factors, which is of course very relevant to communication, where we can have lots of different variables and it can change depending on the person who is kind of leading or initiating the communication and the person who is on the receiving end of that. So a realist review often is performed in 6 steps. So I've put those up here for you. But there can be a bit of variation, and it's often viewed as an iterative process, so this can be quite cyclic. So it begins with locating existing theories. As I say, it starts and ends with theory. We then move on to searching the evidence base, then selecting the documents that fit within our research questions and our topic, then extracting the data from those documents, then synthesizing that evidence in order to form a final, what we call program theory. So that is a theory of actually what and how does this work. Okay, so our review aims, question and objectives. So the aim of the review was really to understand how to improve communication of prognostic uncertainty in what we deem to be potential palliative and end-of-life care settings. And we say potential because this is uncertainty. This setting in itself, of it being an end-of-life care context, may in itself actually be uncertain. So the research question is really looking at the kind of how, why, for whom, and in what context does this work or not. And then our objectives were to conduct this realist review systematically, to develop a program theory for communication of prognostic uncertainty within the palliative and end-of-life care contexts, and then hopefully to make recommendations for actually how can we improve this, how can we do this better in practice, and what might be best practice actually of disclosing and discussing prognostic uncertainty. So our inclusion and exclusion criteria. So we tried to take quite a broad and inclusive approach to reviewing the evidence. So we've included all documents and study designs with any kind of relevance to our program theory, so any kind of relevance to communicating prognostic uncertainty. We've limited it to adult patients as we identified that there are differences in terms of communicating with children and parents compared to adult patients. But we are including different forms of communication. So that includes written and verbal, but also communication with any form of healthcare professional, so not just doctor-patient, with either another healthcare professional, patients, or carers, or a combination, as it may be. So we are excluding only children and those contexts that we're confident do not relate to palliative and end-of-life care settings. So stage one was to develop an initial program theory. So this is our messy first draft, if you like. So this is what we came up with from doing a brief scoping search, looking at the literature, looking at the key papers within this field, and kind of pulling out the key concepts and findings and mapping those out together into this diagram. So I will just briefly talk you through some of the main points that we've identified so far, but we are looking to interrogate this with the evidence from the main search. So in the middle, we have our main topic of communication of prognostic uncertainty. And then we've got two scales there, which seem to have some kind of link to each other. So the top one is on the clinician-receiver relationship. So actually, is that a strong relationship, or is it a weak or maybe a new relationship? And then we also have a communication scale with one end where the communication might be very implicit, and on the other end where it might be quite direct or explicit. And it seems that if the relationship is weaker, you might be more likely to fall towards this implicit communication side. And actually looking at this is kind of on the left-hand side of the diagram. It may be that the uncertainty is actually expressed as certainty. So in the example that I gave earlier, for example, this can lead to negative framing, which could lead to these more negative outcomes, potentially of distress, hopelessness, or the patient actually just feeling really abandoned by the system. But on the flip side of that, it could actually lead to overly positive framing of the situation. So that might actually have outcomes such as false hope, or actually patient and family members not really understanding the severity of the condition or not understanding the uncertainty of the situation. So that could lead to outcomes such as family members who actually have identified this themselves, actually feeling burdened with the responsibility to communicate that to others. It could lead to patient and family distress due to the unexpected health changes that will likely occur in the coming time. It could lead to unresolved bereavement narratives or just distress and denial. So quite a lot of negative outcomes there, potentially, if that's handled poorly. But on the other side of that, if the communication is more direct or explicit, there's different contexts for when that might occur. So it might be that the clinician decides they have a good tolerance of uncertainty and they decide to initiate that dialogue, but actually could also be initiated by the patient or carer. And the clinician tendency to initiate that might be impacted by things like their skills, their knowledge, their level of experience, and actually the training and support that they're given and how to approach these conversations. And the context that may be linked with this being done better are assessing and establishing the patient's understanding of their own condition and actually having consent to disclose prognostic information and to have that conversation within that setting, that it's the right time for that person. And that can also be impacted by things like the patient and carer's kind of psychological readiness to talk about the prognosis. So if all of that comes together and is done well, there is a potential that the patient and family actually do understand the uncertainty of the situation, and that would give them more kind of preparedness to engage with advanced and end-of-life care planning and make informed decisions about the future and about their priorities for what comes next. Okay, so the next step was to search the results. We searched multiple different kind of databases and sources of evidence. So what you can see in this diagram is we initially selected potentially thousands of documents that might be relevant to our review, and then we whittled that down with our inclusion and exclusion criteria. We've had multiple different people looking at that, interrogating it and checking each other's work. And what we've ended up with is 206 documents to include in the final review. So we've managed to pull together quite a lot of evidence for us to look at and synthesize the key findings of those pieces of evidence. So that's where we're up to. So we're currently on the extraction and synthesis phase of that. So I don't have results to share yet today, but in terms of our anticipated impact and dissemination, we're planning to work with Marie Curie as the funders to draft a report on recommendations for how we can improve communication of prognostic uncertainty. We'll also be publishing the findings open access in a peer-reviewed journal and sharing the results widely through other platforms as well, such as with our clinical networks and key policy makers. So we're hoping that out of that initial program theory diagram that you saw will be refined down or become much clearer, and that it may actually turn into a bit of a model actually for how we can communicate and how we can best approach these conversations in practice. And we're hoping that the resultant theory will also help us actually just map out some of these outcome pathways for communicating uncertainty, and actually when it might work so well and when it might not, and the effects of this. And the review is considering international evidence, so we haven't limited it to UK context, so it might have international relevance, but we will also be contextualising the findings specifically within UK policy and practice. Thank you very much.
So thank you very much, Katharine, for letting us know how that review is going. I'm going to stop sharing for a moment, and we're going to break a number of points throughout the session for some questions. So I'm just going to have a quick look to see if we have any questions in there at the moment, and we do not. So I just wanted to ask you, Katharine, talked about disseminating the findings, and I recognise it's difficult to say much about the findings themselves at this stage, but do you have a sense of who these are going to be relevant to? Who are the kind of key stakeholders, and who would they be relevant to?
Yeah, I mean, I think particularly clinicians and clinical settings, I think there would be a tendency with this to only share it within the palliative care context, such as only sharing them with hospices and specialists within that field. But actually, I think that we acknowledge as a review team that actually it could be other members of the team having these conversations. It could be primary care clinicians. It might be other specialists within hospital settings. And actually, it'd be better to equip all different kinds of clinicians and healthcare professionals actually potentially with how they could improve this communication and be the ones to actually engage and initiate in that conversation, rather than to leave it down the line to somebody else, or to leave it until we're definitely certain that somebody's going to die because they've lost consciousness, for example, and it doesn't become as uncertain anymore. It becomes something that's definitely going to happen soon. So I think we'd want to share that ideally quite widely within the healthcare sector.
Yeah, I agree. And how about, I mean, I suppose I'm wondering, is there anything from what you found so far from the initial program theory that perhaps might be helpful for patients or carers to know, sort of from that side?
Yeah, I think potentially about the initiating the dialogue. I think maybe it's something we didn't expect to see so much evidence about, that actually, ideally, maybe we would think that the healthcare professional would initiate this conversation. But if they have a reluctance to do so, that it can be the patient and carer who can be the ones actually asking these kind of more difficult and sensitive questions, and initiating that dialogue and having actually the confidence to do that, and not let the healthcare professionals get away with it, and kind of avoid the uncertainty and discomfort of that, and to kind of begin that narrative so that they can get the information that they need, and kind of hopefully feeling empowered to do that, so that they're not left just feeling unsupported and unsure.
Yeah, it's going to be really interesting to see how much that comes out of your findings, and looking forward to the final version of the program theory. Well, I think we'll move on to our next speaker, but we will have another opportunity for questions at the end. So do keep putting your questions in the chat and the Q&A, and we will come back to them. But now I will hand over to my colleague, Chloe Shaw, who's a postdoctoral research associate in Bristol. She's been working on the Oscar study and has already shared her slides. So over to you, Chloe. Thank you.
Thank you, Simon. Hi, yeah, so my name's Chloe Shaw, and my co-author is Professor Lucy Salmon, and the talk that I'm presenting today is Communicating Uncertainty about Quality and Length of Life in Advanced Kidney Disease. So for people with advanced kidney disease, dialysis is one of the main treatment options available. Older patients with kidney failure often have complex health needs and comorbidities though, and the evidence suggests that the survival benefit of dialysis is either lost or greatly reduced for this group. Dialysis also has a high treatment burden, which can negatively impact quality of life. So conservative kidney management is a palliative treatment option which focuses on controlling the symptoms of kidney disease without dialysis, and is considered a beneficial alternative for older patients, particularly those with comorbidities and poor performance status. However, there is considerable variation in rates of conservative care for older people, ranging from 5 to 95% across UK renal units. Deciding between these treatment options is challenging because there is uncertainty concerning the risk or probability of outcome for these treatments, in terms of how long a person will live and the quality of life they will have. There is further uncertainty regarding outcomes because of the limited research evidence, known as epistemic uncertainty. And there's also uncertainty about knowing what's best for the individual. So patients prioritise different aspects of their life, which correspond to different treatment choices. For example, some older patients may be willing to trade length of survival from dialysis for maintaining independence and avoiding having to receive invasive treatments in hospital, whilst others may be willing to compromise on some of these aspects of their life to maximise their length of life. So the aim of this talk is to consider how is uncertainty communicated in advanced kidney disease decision-making consultations, and what are the implications. So the data here is video recordings from 4 renal outpatient units across the UK, which form the OSCAR study, which stands for Optimising Staff-Patient Communication in Advanced Renal Disease. So the data was collected between July 21 and January 23, and we collected a total of 110 recorded consultations, and we focused then on decision-making sequences within those consultations, and we transcribed and analysed them using the method of conversation analysis. So we have published some of this research, some of our findings in BMC Nephrology, and then we have another paper which is forthcoming. So we found 2 main approaches to framing conservative kidney management in the data. So the first and more common approach is where CKM is framed as a subordinate option to dialysis. For this approach, the uncertain benefits and risks of dialysis were minimised. The less common approach is where CKM is framed as a main option. A main option with dialysis. For this approach, the uncertain benefits and risks of dialysis were emphasised. So what I'm going to do now is give you an example of each of those approaches with an extract from a conversation for each. So the first approach is where CKM is presented as a subordinate option, and there are a number of features which tend to go together and which frame CKM as a subordinate option. These include CKM is not framed as a clear treatment option. It's often appended to the main decision-making sequence and not labelled as a clear treatment option or as conservative kidney management. We often see minimal or no details of what is involved, and it's often presented as an omission or as not having dialysis. And not having dialysis may also be ruled out as not for you. CKM is framed as a minority preference in this approach, so something which some people choose. And CKM is not clearly presented as having benefit to the patient. And what we see is that the uncertainties and the risks of dialysis are minimised or not mentioned. Okay, so I'm just going to point out a few key features in this clip. So when not having dialysis is raised, it's almost appended to the main decision-making sequence. It comes after the consultant has talked through dialysis treatments and justified why she has raised this now in terms of choosing the most suitable dialysis option. It's also not labelled as an option or as conservative kidney management, but as not having dialysis. It's framed as a minority choice made by some people, whereas we don't see this happening in the same way when dialysis is introduced. The consultant then discounts this option for the patient as he doesn't belong to the category of people she's describing. CKM is not framed as something positive in its own right. And choosing not to have dialysis is again framed as a preference chosen by a minority, the odd patient. Crucially, the clinician has not framed the option of not having dialysis as having potential benefit to the patient. And what we see here is that there are no apparent risks or uncertainties introduced with having dialysis. The risk to quality of life of dialysis being too much of a burden is not framed here as personally relevant to the patient, but is ruled out for this patient. So now we turn to the alternative approach, which is where CKM is presented as the main option for the patient. And again, there's a number of features which go together and which frame CKM as a valid option for the patient. So CKM is framed as a clear treatment option. It's introduced as part of the main decision-making sequence. It's labelled as a clear treatment option and as conservative kidney management, and we see the details being provided of what's involved. CKM is also not framed as a minority preference here. And the potential benefits of CKM and the risks and uncertainties of dialysis are described in this approach. Okay, so I'm just going to point out some key features here. So, although conservative kidney management is presented last here, it's not appended, but it is presented as if one of a list of options. So not having dialysis is introduced as an option from the off, rather than starting with some people choose, and it's labelled as an option. It's also labelled as explicitly as maximum conservative management. An uncertainty is introduced with regards to the option of dialysis, both in terms of risk to length of life and in terms of what is known or the evidence. We see conservative kidney management being presented here as a popular rather than minority option. An emphasis is given to conservative kidney management as a treatment through the word maximum and specifying what this means as an active treatment. Again, as part of introducing conservative kidney management as a main option, the clinician is introducing uncertainty with regards to the option of dialysis. Here the evidence is uncertain, and it's not certain the patient would live longer, and the disadvantages of dialysis are conveyed as significant, with possible implications here for the patient's quality of life. So we have identified a pattern in the way the conversation unfolds depending on the approach used by the clinician. So the key difference being in terms of how much interactional opportunity is provided for the patient to engage with the option of conservative kidney management. So when conservative kidney management is presented as a subordinate option, the sequence tends to be moved on away from the option of not having dialysis, and we tend to see minimal engagement from the patient. But when CKM is presented as a main option, the patient's perspective is frequently invited through questions such as, what are your thoughts at the moment? And we are more likely to see the patient assessing conservative kidney management as a valid option. So we've also found that patient scores of shared decision making on a survey they completed after the consultation was significantly higher when conservative kidney management was communicated as a main option, with no significant difference to the consultation length, both having a mean of 23 minutes for both approaches. So overall, we have found three important dimensions of framing risk when communicating treatment options in advanced kidney disease that are important for patient engagement with conservative kidney management. So firstly, conveying uncertainty about the potential benefit of dialysis to length of life, conveying a potential risk of dialysis to quality of life, and conveying uncertainty as personally relevant to the patient. And more generally, communicating uncertainty may have important implications for engaging patients with alternative treatment options. And we'd like to thank the rest of the study team, the project advisory group, and our PPI advisors and the NIHR for funding this work. Thank you.
Brilliant. Thanks very much, Chloe. It's so interesting to see how the communication pans out at the level of the conversation itself and the different phrases. We do have a question in the chat, but can I just ask, first of all, just quickly, you mentioned that framing chronic kidney management as an option increased satisfaction with shared decision making and that metric. Did it change the decisions people made? Did more people who had the shared decision approach choose chronic kidney management, or did you not collect that data?
Well, it's a tricky one because I think it's sometimes these decisions are made kind of quite ahead of time, so and then they can change for different reasons. So we haven't looked and focused in on that specifically for that reason. But yeah, I think in terms of the engagement was key in the conversation in terms of how much space was provided for them to kind of ask questions and talk about it within the consultation. Yeah.
Thank you. And then Sarah Bowers has just asking, she says, very interesting study, likes the real world data collection. Did you experience any challenges in this study method with ethics approvals or any biases where people changed what they were saying if they knew they were being recorded?
I think in terms of, so the second point, in terms of people changing, I think that's a common concern with this kind of collecting data, like of people having conversations. But actually, you see the variation in the different approaches, and within, you know, individuals can use different approaches, and so I think people still have a tendency, you know, still people communicate in the way that, in variable ways and in kind of natural ways, if you know, so I don't think I think people get used to having the camera there, and I think because often, you know, communicating is so quick, you know, you don't really have time to stop and really consider. It's kind of, it flows. So I think for people to really change their practice because of the camera would be, I don't think we tend to see that happening in an obvious way. Yeah.
Thank you. No, that's good to know. And then just another question. Why do, Ikumi's asking, why do approaches to uncertainty regarding chronic kidney management vary? Is it just because of differences in doctors' attitudes towards chronic kidney management, or are there other factors that you think might be involved?
In why there's varying approaches?
Yeah. Why do they? What affects whether a clinician will introduce it in one of the two ways that you described?
So we didn't find that it was to do with the patient necessarily, because we collected that data to do with age, and we didn't find any significant differences for the patient. But then I think there are key challenges and barriers that clinicians are faced with, and I think there's cultural different what's going on in different units. I think dialysis is kind of seen as the default option often. That's a big cultural, it's ingrained within medicine in a way, and I guess that part of that is the tendency to want to treat and do well for the patient and do, offer something in that way. So I think there's lots of different aspects, and further research is, we've Lucy, who's led the project, that has been a big kind of driver, is to understand all those different aspects, and there's further work that's that will be coming from that study to look at that. Yeah.
Great. Looking forward to seeing what you find out next. Well, thank you very much, Chloe. We'll move on then to our third speaker, who is Rosanna Fennessy, postdoctoral research associate in the University of Cambridge, and she's going to be presenting on some work to co-design a toolkit for communicating uncertainty in multimorbidity. So over to you, Rosanna.
Thank you. Thank you everyone for listening to our third presentation on communicating about future uncertainty. And thank you, Simon, for agreeing to work the slides for me as well. And I actually want to talk to you this afternoon about some work that I'm doing with Simon related to experiences of uncertainty communications in older adults with advanced multimorbidity, and the development of a co-design toolkit to optimize those conversations about future uncertainty. So we've heard lots this afternoon about how uncertainty about the future is an inherent part of illness experience. But for older adults with advanced multimorbidity, that's particularly the case. Unpredictable illness trajectories, complex and often sort of conflicting treatment plans, often based in a fragmented healthcare system, means that for this particular group, this is a very sort of important aspect. So we wanted to look at optimal ways to communicate about future uncertainty in this population. We designed a multi-method, multi-perspective qualitative study that was run over 2 phases. In our first phase, we were interested in finding out about the experience of uncertainty communications that patients, informal carers and health professionals had had. We did this through in-depth interviews with a number of patients and their informal carers. And these were patients who were over 65 with 2 or more long-term conditions identified on a modified scale of palliative care need. And we also conducted 3 focus groups with health professionals in palliative care settings, rehab settings, and geriatric settings, a diverse range of health professionals, doctors, nurses, healthcare assistants, therapists, chaplain, a psychologist, who typically work with this population. Our initial analysis of the interviews and the focus groups here, we developed a thematic analysis of that, and then in conjunctions with our patient and public involvement group, we then developed some initial ideas for a toolkit that we took to 2 stakeholder events that were also with patients, carers, health professionals and some researchers, and developed a number of scenarios and worked on that to refine that further into the toolkit that I'm going to talk a bit more about now. So I'm going to start, sorry, Simon, if we can have the next slide, please. Thank you. So I'm going to start by talking about some of the findings from the first phase. And what we noted was that all our participants, whether they were patients, carers or health professionals, acknowledged the ubiquitous nature of uncertainty in advanced illness. So they were all aware of it being sort of an inherent part of their experience. However, we noticed different responses, and we found these responses across all of our groups, whether it be patients, carers or healthcare professionals. So we had, first of all, an acceptance of uncertainty. So the quote example on there is from one of our patients. So this is someone who accepts uncertainty in all aspects of their life, not just illness. So why waste time thinking about things you've got no control over? And we often call this the que sera sort of response to uncertainty when we were working on this. And in our healthcare professionals too, there was acceptance of uncertainty. The quote that Simon gave at the beginning of the presentation, it's the air that we breathe. So for the health professionals in our setting, it was very common for them. We also noticed avoidance as a response to uncertainty as well, and Katharine alluded to that in the things that she was talking about earlier. So avoidance in patients, one of our patients said it's in the too hard category, thinking about anything that led to situations with a lack of control or possible future uncertainties were to be avoided. But in health professionals too, the need to narrow down and to try and get answers to everything meant that uncertainties were avoided and not addressed with patients. And as I've said at the bottom there, that whichever of these responses we were experiencing, the outcome is that they can inhibit conversations about future planning. Then when we looked at barriers to optimal communication and experience that our participants had, we did note differences across our groups. So for patients, particularly important was the personalised care relationship. Having a conversation with a health professional that knew you and knew your background and your unique nature of your health conditions was very important. And then that was also led on to this largely a need for honesty and openness. There was a caveat to this that I'll talk about a bit more, but largely our patients wanted honesty and openness. And the quote here from our patient, the doctor, she's lovely, she'll tell me the truth because she knows me and knows just what I want, really illustrated that. And actually for many of our participants, situations where healthcare professionals didn't have an open conversation actually increased uncertainness and anxiety by, why is the doctor not talking to me about this? Is there something else that they're not telling me? For our health professionals, there was more a focus on the dilemma about feeling confident about whether those differences understanding the differences between whether the uncertainties are genuine uncertainties that nobody knows the answers to, or whether the uncertainties are a result of a person's lack of clinical knowledge and feeling confident about which of those two it is. And that also led on to this idea. A number of our health professionals commented on their lack of experience or confidence in undertaking these conversations. There was a great deal of concern about potentially upsetting patients or losing their trust or confidence. And the quote here from our health professional, it's about communicating in a way that still keeps that confidence and trust, but also making it clear that you don't have all the answers. So then we developed our, as I said, through our stakeholder groups, our sort of toolkit to address future uncertainty. And I'm going to talk about these three sections in a moment. Timing and preparation, so getting ready for those conversations, communicating openly within negotiated limits, so setting the boundaries of those conversations, and then finally signposting support and planning, so what's in the conversations. And all three of those sections are surrounded by the two factors on the left and right hand side, that they are done in that trusting care relationship that was particularly important to our patients and carers, and in recognition of the unique nature of our patients' multimorbidity, that it is a very personalised approach. So first of all, timing and preparation. So I've said within that trusting care relationship and understanding the patient's unique situation, consider opportunities for conversations. The scenario that Simon presented at the beginning with James, there were opportunities for conversations to have happened there, but they didn't take place. So transitions of care might be an example, or when inconsistent communication is highlighted. Patients and carers in our study often said that they went into consultations with question marks left from the other conditions that they had with other consultants. That should be a trigger to start those conversations. For health professionals, they should try and resolve uncertainties due to missing information, so collect that information across those different conditions. Also set aside particular time to have these conversations to make sure that the right people are there. So patients and carers often wanted loved ones present. And also encouraging patients and carers to prepare for the conversations too, encouraging them to write down questions. And our patients and carers did comment on the usefulness of a prompt list, for example. And then setting the boundaries for these conversations. So starting off by exploring the understanding and expectations. So what do patients and carers already understand about their multiple conditions, and what do they expect to happen in the future? And then negotiating the limits of openness to discuss uncertainty. So as I mentioned earlier, the vast majority of our patients and carers wanted honest and open conversations, but that wasn't the case for all. Not everyone wanted to know all the possible future outcomes that there may be. And in some cases, it might be more appropriate for healthcare professionals to hold some uncertainty for their patients. I think what was important was aiming for this shared understanding, a safe uncertainty, sort of removing the uncertainties that patients want removing, but still being aware of the limits of what patients and carers want to engage with these conversations. And crucially, to address the fact that in these patients with advanced multimorbidity, that the interactions of their multiple illnesses means there are limits to the extent of the uncertainties that health professionals can address. And the quote from our patient at the bottom here really sort of sums up what it is that they wanted to get from these conversations. They didn't mind health professionals saying they weren't sure, but what they did mind was saying, well, we don't know, and we're not going to do anything more with that. And the third part of our toolkit, which is actually what happens in the conversation, so just linking it back to that quote. We know from our patients and carers in this study and from the wider literature that even in situations where practical options are limited, there won't be any more treatments for that particular patient, that they still want to feel continued support from their healthcare team, open communications, and a line of contact at all times. Something that could also be emphasised in this setting would be to engage in more parallel planning. So to plan for all eventualities, as we've got down there, look at optimistic scenarios, but also think about potential worst case scenarios. This allows space for hope for patients and carers, but balance with the realism of their complex situations. focusing on that complex situation, not just their single illness, is also crucially important. And to understanding that this is not always easy to do, but to sort of get that messaging consistent across multiple providers, to share the results of those conversations where that's able to happen through recording systems. And then finally, our takeaway messages, I suppose, conclusions and practice recommendations. We know that uncertainty communication is a core skill for health professions, and we know that if it's done well, it can reduce patient distress, facilitate decision making, and crucially for this population, enable future care planning. But we know from the participants in our study that training health professionals is a key way to ensure that this is done well, particularly in the complex situations of patients with advanced multimorbidity. To be able to do that communication well, we've described requires an individualised approach, so that person's unique situation and those honest and open conversations, but negotiated within the limits that patients and carers want. And as I've said, focusing on parallel planning supports patients to be able to consider multiple uncertainties and allow space for hope, but also help health professionals to communicate positively, as well as outlining the reality of the uncertainties in this particular patient group. Thank you for listening, and thank you to all our patients, carers, health professionals who took part, our PPI team and colleagues who helped put this on, and our study is supported by Adam Brooks Charitable Trust.
That's great. Thank you so much, Rosanna. Can I just ask you, you've described really clearly the sort of development of this approach to communication. What's next? How's this going to be implemented? What's needed for that?
I think what we would be hoping to do next with this is actually to develop an intervention of some kind, possibly based around scenarios and things, to engage in some training with health professionals and then to evaluate that. We certainly in the development of this had health professionals who have a familiarity with working with this population, and it would be really interesting to be able to take these ideas into with other health professionals, other settings. Primary care would be a good example that I can think of, where we would like to sort of try this out and then evaluate it as a tool for health professional training.
Thank you. And a question from Sarah. Did she highlights that there's work in cancer showing that patients prefer optimistic conversations, especially around prognosis, and there's some data to suggest that if you're open about poor prognosis or uncertainty, that can reduce satisfaction. Did you find that patients had a preference in the study about how honest they wanted conversations to be, or was there a range, or how did that look?
I think there was a range, and I think I was quite struck by several of our patient participants that they already had a considerable knowledge themselves about their conditions and sort of, you know, their likely trajectory. So I think I can remember one patient saying it's no use the doctor trying to sort of be over optimistic when that you clearly can see yourself that things might not be going in those directions. So there was a range, but we did also have people who did want to have those positive conversations, because that also gave them confidence and hope. And I can think of one person in particular who did say that. But I would say on the whole, our patients preferred the open and honest approach, but doing it in that way where it was looking at all scenarios, so optimistic ones as well as potentially negative ones.
That's brilliant. Thank you very much, Rosanna. So in the last 10 minutes, I'm going to attempt to sum up and bring together some common themes. Please do continue to put your thoughts and questions in the chat, because we will try and answer a few more in the next few minutes. But I thought I would just say a few more things about uncertainty, trying to pull it all together. So just thinking about common strands. So it's clear that uncertainty is an issue across many illnesses, and it affects patients, families, and health professionals in a variety of ways. Not knowing can be challenging and it can be distressing. However, we can't always reduce or eliminate uncertainty. Communication of uncertainty is important. It's a core skill in palliative care, and what we say and how we say it matters. How we frame it matters. Usually, it's better to communicate uncertainty openly, but as we've just heard, not always. And approaches need to be personalized. There's a negotiation about what is appropriate to say and what is helpful for someone to hear. And ultimately, what should we be aiming for? I think we've had 3 talks that have given us different lenses on this issue of uncertainty using different methods, the realist literature review, the conversation analysis, and the qualitative co-design. Ultimately, what are we aiming for where there are situations of uncertainty? Well, this is quite an old model now. It's back from Mason in 1993, who proposed this idea of unsafe uncertainty. And Mason argued that there are 2 scales that are relevant. There's the horizontal one from certainty to uncertainty, but there's also this vertical one about unsafety to safety. We can't always go horizontally. We can't always go from right to left. We can't make things certain when they're not. And that's particularly true about the future and particularly true in serious illness contexts. But what we can do is we can make people feel safer. And by optimal communication, that's one way of doing that. We've recently asked similar questions in a focus group study of people involved in the care of people with serious illness and some patients and care representatives. And we asked them what is good? What does good look like when faced with uncertainty from serious illness? And the synthesis was this phrase: finding security and uncertainty together. And that incorporates some of the things that we've heard about: a trusting relationship, personalized care, reframing uncertainty in such a way that it can be considered neutral rather than a negative thing, and then planning for different scenarios. If there's more than one thing that can happen, why would we make one plan? We need to think about more than one possible future outcome and help people feel safe in multiple possible future scenarios. Bring it all the way back to our patient James. I think communication could have made a big difference there. If the health professional had said this rather than, no, it'll be fine, then perhaps there would have been an opportunity for James and his daughter to think about how they wanted to spend their time, think about the future possibilities, and things could have been different. So thank you very much. I'm going to stop there. We now have an opportunity for the next 4.5 minutes or so for any reflections or discussions. And I can see Julia O'Keefe's got a reflection, I think, that many hospices do provide communication skills training regarding sensitive issues at various levels. And there's a need for communication training within generalist settings. Listening is a valuable skill that is often lost in busy services. And one of the things I think I was most struck by today was, Chloe, the finding from your study that introducing the 2 options equally and sort of foregrounding the uncertainty didn't take any longer. Because I quite commonly on the wards speak to colleagues and they say, well, we just don't have time to have these conversations. And I'm now going to go back to them and say, well, it doesn't take any longer. So I think that's a really important point. And I think it's also important to find ways to make this not just specialist knowledge. Communicating well with our patients shouldn't just be specialist knowledge. And in specialist palliative care, we prioritize communication for important reasons. But it's something that we all need to do. And uncertainty exists throughout healthcare. So hopefully we will see in future more efforts to train communication. Just got something from Nicola Glennie saying that she's working with people with M&D and uncertainties an issue for both them and health professionals, inhibited by lack of community care. So conversations are repeated multiple times with different professionals. Is that something you're nodding, Rosanna? Is that something that came up in your study? Can you say something about that?
Yes, actually, I mean, there's only so much time to sort of choose things to talk about in the presentation, but I'm nodding because that was something that came up a great deal. And we tried to think of that in the way about trying to, get the dissemination of those conversations across the groups. But certainly for our sort of patient and care participants, they particularly commented on that. So either a repetition multiple times, or the fact that those conversations were very I'm lost my words, but very much in the silo of a particular condition, rather than communicating with the patient about what else is going on with your other conditions and things like that, in certainly in the case of multimorbidity, but also in the sense of a lot of the conversations seem to be focused just on a very sort of narrow prognostic approach, rather than what many of our patients and carers actually wanted to talk about was wider uncertainty about their daily life, their future living, their potentially what will they be able to do in 6 months' time or whatever.
So thinking about the different elements of an illness trajectory, not just how long have I got to live.
Absolutely, yeah.
And Chloe, how about in the renal study? I'm imagining that a discussion and decision making about choice of modality with regard dialysis or chronic kidney management, that takes lots of conversations. Did anything come out from your data about sort of conflicting information across conversations, or perhaps that wasn't quite so much within the study design?
Yeah, I think that has come through in terms of how I think in particular, like planting the seed of the discussion, how it happens often kind of more upstream. And so sometimes the precedents for dialysis, I think, can be laid kind of early on in those terms, in those earlier conversations, because there's an expectancy that that's going to happen at some point. So then it's kind of having to manage that. I can see that the clock's running, so I don't want to end halfway through. So I should perhaps stop there.
Thank you, Chloe. So we have 20 seconds left for the session. I think we will draw things to a close. I hope you found this a useful run through of the different ways in which uncertainty can affect people in serious illness and different approaches to communicating it. This is a really important issue in serious illness. Thank you very much, everybody.